Now follow up with one of my close friends, Dr. Patrick Maloney. He'll be talking about intraoperative imaging, assessment, and complex spine surgery. Take it away.
Good. Thank you. So the topic of this talk was really, I think, more born out of frustration, of dissatisfaction with current intraoperative imaging, and then a little bit of the overlap with some of the preoperative imaging and planning that are available to us in the complex spine world, and ties a little bit into navigation as well. So my disclosures from yesterday. So start off with a quote. As a former Air Force veteran and a fan of history from The Bomber Mafia by Gladwell. So the most expensive project in the war, not a bomb, not a plane, not a tank, not a gun, not a ship, it was the Norden bomb sight. The 50-pound analog computer conceived inside the exacting imagination of Carl Norden. And why spend so much on a bomb site? Because the Norden represented a dream, one of the most powerful dreams in the history of warfare. If we could drop bombs into pickle barrels from 30,000 feet, we wouldn't need armies anymore. We wouldn't need to leave young men dead or on battlefields or lay waste to entire cities. We could reinvent war, make it precise and quick and almost bloodless, almost. So, sometimes spine surgery is a little bit like warfare. We're trying to be precise, make it bloodless, almost, and be more accurate. So just a brief history in general. Medical imaging, x-rays have been almost 128 years old now. Röntgen had the first x-ray were done in Germany, and he was given the Nobel Prize in Physics at the turn of the century for his work. It wasn't for another 100 years that Dr. Hansfeld utilized the CT, where he thought that many, many x-rays in different planes could make a 3D rendering of body cavities and anatomy. And the first CT was done on a cadaveric cow. And he also received the Nobel Prize in Medicine for his efforts in 1979. And then around the same time, an American chemist, Lindbauer, whose background was in nuclear magnetic and spec, conceived the application of using magnetic fields on biological objects to demonstrate their chemical structure, and this was the foundations of our now MRI, and he also received a Nobel in 2003. So, imaging in spine surgery is an absolute necessity. We've talked about navigation, we've talked about preoperative imaging, and evaluation. We have a variety of modalities, and it seems that the more modalities we have, we're adding, we're not subtracting. So our patients routinely will have CTs, they will have short x-rays, they will have dynamic x-rays, they may have CT angiograms, myelographies, 3D renderings, and this is all in an effort to make us accurate and to plan our surgeries and to diagnose the pathology and execute our surgical plans. So again, for spinal deformity, a mainstay is going to be our long film x-rays. Typically for my patients, I'm getting CTs of the total spine. MRIs, a little bit more selective, usually lumbar for sure. And then if any signs of myelopathy, I will add on a cervical and a thoracic. Some centers will just do a whole spine MRI, and if there's significant pathology, zero in, which is nice. That's a bit faster scan. And then now we have whole body x-rays. The EOS, which has been shown to have highly accurate one-to-one renderings of the entire skeletal system at a lower dose of radiation, which is just fascinating. So barriers to accurate imaging assessment, a lot of them are patient-driven. So osteoporosis is a big one. Our patients, even in the osteopenia category, we'll show a case example at the end, can have really difficult imaging intraoperatively in evaluating the bony structures. Obesity, soft tissue density is a big barrier, especially in the thoracolumbar region. If they've had any medical devices, so our patients who've had implants, pumps, previous instrumentation, our degradation on MRI imaging for sure will be difficult. And then obviously just severe deformities and appreciating axial, sagittal, and coronal malalignment can make the evaluation problematic. So what's the role of the surgeon here in ordering imaging both intraoperatively, preoperatively? Well, in general, we're balancing a lot of factors. How long is this going to take? How expensive it's going to be? Will insurance approve it? Is it going to make me more accurate? Is it going to make me faster? What's the radiation exposure to myself, to my patients? Is it a pediatric patient? Is it a tumor patient? Are they going to be requiring future imaging, whether it's MR or CT? And there's a lot of survey in the literature regarding radiation safety in California. You have to have a license to operate that for my California surgeons. Everyone's familiar with our fluoroscopy license and your CMEs for that. Many other states won't require it, but California will make you pass a standardized test to operate a fluoroscopy intraoperatively. In general, most of us trained on using intraoperative fluoroscopy. ORs now, especially for our vascular colleagues, they have biplane hybrid ORs. For most of my cases, if I'm calling for intraoperative imaging, they're just going to wheel in a fluoro. Sometimes a plain film or even a long film is nice for a long segment, but most of us are very facile and familiar with the usual landmarks of intraoperative fluoroscopy and evaluating bony anatomy and trajectory of screws, evaluation of spinal alignment. But it's not very quantitative. It's difficult to do intraoperative measurements and calculations unless you're going to pair that with 3D navigation. And in general, again, if patients have a lot of bone loss, typically our osteoporotics, it's going to be more challenging to have fluoroscopy. Ultrasound was talked about earlier, but yesterday, I think for intradural surgery and for decompressive operation, it is a useful adjunct. I do use it for my intradural cases, especially tumors or patients with cysts. I think it can be useful for evaluating cervical decompressions, but in general, it's going to be limited in terms of the bony structures. So I think now the technology is starting to, really ramp up, and we're taking a lot of preoperative images and doing, 3D rendering from 2D images. This was a study looking at the EOS using 2D long films and synthetic phantom scoliosis patients, where they were able to map out within 1 millimeter of accuracy each vertebral level. It was very impressive, just being able to regenerate a 3D construct off of a 2D image. Just some representative images from the study showing how accurate the different points of analysis were, both in rotation as well as morphology, looking at end plates. I think this is not quite ready for prime time, but it's getting there in terms of being able to do that. One thing that we're using more now, and that I started using toward the end of fellowship with Dr. Ames, was intraoperative long segment images with the O-arm. This is an acquired collimated image where you're essentially getting 1 to 5 millimeter thick slices, and you're able to cover usually up to C7, almost all the way down to the top of the femoral heads, depending on the machine. And it will adjust for tissue density, previous instrumentation, and there's no stitching. There's no manual stitching. We'll talk about some of the parallax or issues with the intraoperative long film for O-arm, but this is another very useful tool for the surgeon intraoperatively to be able to evaluate the type of correction. I think we spend a lot of time looking at where there are neuromonitoring changes. Do you spin and nav going in? Do you do a post-confirmatory spin? One of the areas that we don't always check is how were we on our intraoperative correction? Patients on the table, that's your time to make an adjustment. And in general, what's going to give you the best image and cover the most segments to allow checking of whether or not you've executed your surgical plan. We're a little bit limited in the operating room to be able to do that. So Dr. Pauly had a nice study evaluating just the accuracy of this collimated O-arm long film 2D and then comparing that to the CT. He found that in general, there was strong accuracy in terms of different patient positioning, an agreement between the CT and the collimated reconstructed image. But one thing the study was highlighting is the parallax effect. We have patients here in the classic prone position, maybe for a cervical thoracic case and a little bit of reverse Trendelenburg, and then having the device orthogonal or a patient slightly bent with the beam coming in. The off-axis image, long film, showed the most disagreement in terms of correlating it with the CT findings. So, intraoperatively, depending on how the patient is positioned, depending on how the O-arm is positioned, and how you run the long film, you can have artifact parallax and distortion of the image when you're evaluating the overall alignment. Stitching. So at our institution, until we were able to upgrade with whole body x-rays, we had a stitching program that was automated. Some hospitals use the manual process, but essentially you're taking an AP and lateral x-rays of the cervical thoracic region and then thoracolumbar sacral region, and then bringing those images together. Many times the source images are not stored in packs, and the surgeon or the radiologist is not aware of how the image was properly put together, whether it was done by a tech or it's an automated process. But most hospitals have a stitching type program for your long films. So, errors in stitching, especially with preoperative planning. No method is 100% accurate, but you never want to get messages from your preoperative engineer saying there was a major stitching error, there was a complete exclusion of a vertebral body, your surgical plan is off, your rod is potentially incorrect, we think that the patient needs to be re-imaged. I think this is probably an underreported issue for long film scoliosis patients, and many surgeons may not be totally aware that there is a stitching error. So they did a retrospective study at a single institution center looking at stitching of both their instrumented and uninstrumented cases for pediatric, and found that it was up into 16 to 14% had some type of stitching error. Whether it affected the execution of surgery or planning of surgery, it wasn't having a significant impact, but if it's not appreciated by the surgeon, especially when planning it, it certainly can. And then just some quick case examples. So, before our whole body x-rays, this is a lot of my patients, obese, with deformity. You can see, we're able to see significant sagittal plane malalignment, previous lumbosacral construct, but, the coronal evaluation on a long film is not very useful or accurate. And even after, the placement of hardware, she underwent a PSO and T10, we got nice correction. We're able to see a little bit better representation of her true spinal alignment, but it's still not great image quality. Moving that to intraoperative, again, taking advantage of the 2D long film. This is a 31-year-old female with progressive adolescent idiopathic scoliosis. We can see nice visualization of what we wanted or needed to achieve intraoperatively. Again, preoperatively, the stitched image, there's no grading on the overall accuracy, but yeah, it was still useful enough to be able to pre-surgically plan and complete her case with custom rods and a staged procedure. Postoperatively, the images that you can get in the hospital, you can't get long-standing films. So many surgeons, or at least resort to, I get a thoracic and a lumbar, and I try and make sure that nothing has shifted to any significant degree, as to have some type of baseline. More recently, since we got a whole body x-ray, I think it's really been a game changer for the hospital in appreciating not just accurate spinal pelvic alignment parameters, but also patient counseling, education, and pre-surgical planning. So as a candidate patient for an extension of a previous lumbosacral fusion, you can just see the difference in the image quality that it makes in terms of being able to look at the compensatory mechanisms, as well as accurate measurements in the upper thoracic spine and lower lumbar without having to adjust for the tissue density. More recently, in a patient in the hospital, we've been able to obtain long-standing or long films as an inpatient. We just walk them over to the center when they're ambulatory. Dr. Kim's presentation yesterday of the early mobilization was great. So we now have mandated that all the patients get inpatient standing long films, which has been excellent. So this lady was admitted last month and had rod fracture, pseudoarthrosis, and PJF, and was paraparetic. And so we did an extension fusion to T4, and we're able to get inpatient long films. So in terms of, does it work outside of deformity, or what tools we use intraoperatively that can enhance our imaging? Even in short segment minimally invasive TLIFs, this lady was an L4-5 spondylolisthesis with severe right lumbar radiculopathy. She also had a BMI in the high 40s, and you can see on the lateral x-ray, intraoperatively doing this without nav would have been really challenging to appreciate her bony anatomy. AP, we were able to see a little bit better rendering of the pedicle shadows, the disc spaces, but certainly a challenge if you're trying to do this with lateral fluoroscopy alone and try and identify landmarks. So again, after instrumentation, because of different tissue density with the contrast of the metal, you're able to see a little bit better on the lateral film, but it's still overall poor image quality. And then again, post-operatively, it's not much better to be able to see, how did we do grading our placement of the instrumentation and being able to follow the patient in earnest. And then, the ability to use a, long film that has the ability to more accurate one-to-one measure. You can see where your hardware was placed, and I think follow patients in a much safer fashion. Last case, again, a short segment, lady also obese, poor bone quality, osteopenic, not osteoporotic, but she was too frail and deconditioned for a long segment, so we just did a fractional correction, 2-level TLIF for coronal malalignment and foraminal stenosis, and she did well with the operation, but again, using the 2D long film to give a better rendering of where our instrumentation is versus fluoroscopy alone. And even though she was normal bone density in her lumbar spine, it just shows that in a combination with tissue density, patient's own bone mineral density, and the high BMI, fluoroscopy alone is unsatisfying to render accurate images of where you need to go. So I think these cases can be benefited from navigation, obviously, but evaluating overall alignment navigation is going to be difficult in giving you that type of feedback that you want. So take-home points. There's a variety of pre- and intraoperative imaging modalities to surgeons. No imaging modality is 100% accurate or can be relied upon solely. Processing errors are probably more common than we appreciate and can affect surgical planning and execution. Intraoperative imaging at this time is really not equivalent to what we have in our preoperative modalities, but I think we're getting there in terms of spinal pelvic parameters and being able to make those measurements and compare them in the operating room. There's no substitute for preoperative planning and mitigating potential operative imaging challenges. If you're going to need an O-arm spin, or you're going to have to localize even for a decompression or non-instrumented procedure, use all the tools available to make sure that you are where you need to be to achieve it. And then again, trying to keep a wider picture of what type of exposure we're giving to ourselves and our patients in terms of radiation dosage, I think is underappreciated in terms of especially cases where we're doing multiple intraoperative O-arm spins and following that patient, the lifetime radiation dosage those patients receive, especially early in life. And then if you can think of a new imaging modality, there's probably a high likelihood you would be in consideration for a Nobel based on the last few hundred years. So thank you.